Good morning, everyone. Welcome to this very interesting session on what are the new high-risk populations. And we have, let me introduce myself. I'm the chair for this session. I'm Dr. Punguralli Selvamuthu from Chennai, India. I work with Vayaji Care. My main focus of work is HIV and women. I'm happy to chair this session and share the stage with such good speakers and first congratulations to the good work they have done. As we move to our targets of 90-90-90, we know that we have to focus more on the difficult to access populations. We know we are doing more and more work and focus on the key populations, but also we need to, amongst these, there are a little more difficult to reach populations like the displaced ones, the migrants, the other stigmatized populations as well. And here we have 5 interesting works from different parts of the world who will speak to us on what innovations they have tried in their population and their cohorts to reach this population. So without much ado, we will just go into the session. Our first speaker for the day is Dr. Yusrul Hakim. He's a program manager at the Malaysia AIDS Control for the Global Fund project under the Global Fund. And he will be talking to us on reaching out to the hidden population in Malaysia. And let's hear from Dr. Yusrul Hakim.
Thank you, Dr. Punguralli. Hi, good morning, everyone. My name is Yusrul Hakim from Malaysia. For the past 4 years, I've been working directly with the key population, namely MSM, transgender sex workers, people who use drugs. So today I'll be presenting my presentation about reaching out to hidden population in Malaysia, MSM, transgender, and sex workers in Muslim majority setting where sex is crime. So in this presentation, I walk through 4 components. First is the background of Malaysia and a little bit background of epidemic, HIV epidemic in Malaysia. And secondly, the barriers that we have. And thirdly, initiative to break the barriers, and finally, the moving forward. So as you all know, Malaysia is one of the countries in Southeast Asia with population about 21.2 million. And the majority of population Muslim with 61.2%. Malay is 50.1% and Chinese 22.6%. Indigenous people 11.8%, and Indian 6.7%. So by constitution, all Malays are Muslim. So therefore, Muslim comprise of 61.3%, and Buddhist 19.8%, Christian 9.2%, and Hindu 6.2%. So in terms of a little bit of HIV epidemic in Malaysia, as you can see on the slide. So this figure is in 2016. So in terms of estimate population size that we have in 2016, and also prevalence from 2012 and 2014. What I would like to highlight here is the increasing of prevalence, HIV prevalence among female sex workers, transgenders, men who have sex with men. So these trends continue to increase in current years. As you can see in the slide, you see the trend as I was explaining earlier. The sex transmission is on the rise, as you see on the red color bars. And the trend for injecting drug use is decreasing. So what is pushing people away? So if you can see, I just list down some of the laws and also social situations. So Sharia law, there are many Sharia law that criminalize sex in general, especially for Sharia law is only bound for Muslim in Malaysia, and civil law also for all population. So as you can see, Section 377 is still the main penal code that state counter intercourse against the order of nature. It's a British colonial rules. Other than that, stigma and discrimination, public shaming and dehumanizing, hatred and violence, fear-mongering, social injustice, this will put people away and will go hidden and difficult to reach. So currently, situation in Malaysia is not so friendly on LGBT and other groups and minority groups, but this is not the focus of my presentation today. This is the barriers that we have and how we come around these barriers, and we come up with an initiative. So with these barriers, we come up with an initiative with government and NGO partnerships, and we work closely, not only with Ministry of Health. Of course, Ministry of Health is the main player, but we also work with other agencies and ministries. So through country coordination mechanism that initiated by the government and also funded by the Global Fund, so we expand this country coordination mechanism for not only related to Global Fund, but for other related health concerning community members. So it's involved for other agencies and stakeholders, for example, religious department, public securities, research centers, other ministries, civil society organization, private sector, or other international partners like WHO and academia. So Malaysia is Council comprised of about 46 partner organizations, NGOs or CBOs all over Malaysia. And with that, we work closely with Sector HIV, which is under MOH, and it goes down into at the state and district level. They work closely with NGOs and partner organizations, and we work closely with government clinics, which we refer community members. So I will explain in the next slide how we work closely with government clinics in creating an enabling environment so that access to healthcare are improved at government clinic, and community members continue to use government clinics for their healthcare. So this is an innovative and sustainable approach that we started in 2016. So as you can see, we start with the online outreach and venue-based outreach or social network. Online outreach apply for mainly for MSM, because MSM generally they are hidden. We don't know who they are. But through social apps and social media dating apps, they become visible and able to be reached. So have caseworkers or outreach workers who reach out to them online and refer them for HIV screening at government clinic or community-based testing. But for transgender or sex workers, we still have to go for the venue-based, because there's no way for us to reach out to through online, because it's really difficult. From HIV screening and community-based testing, confirmatory testing, if they are positive, they are linked to treatment and care. Treatment and care, and if they are positive, they go for a non-reactive. If they are non-reactive result, either they go for PrEP and they go back to the social network, then we reach out for them again and remain in the program. So if they're positive, they go for empowerment and treatment, for treatment adherence, so that they'll be able to adhere to treatment and finally reach viral suppression. So this program is client-centered care, where our caseworkers, we follow through since they've been reached and for testing and follow-up for treatment and care. And we have about 85 caseworkers. And it's been recognized as one of the the Global Fund best practices. And we work closely with 52 government clinics, which branded as community-friendly clinics. So the result from 2016 to May 2018, as you can see, overall, all KPs, this is including the PWID KPs, 14,204, and 54% of that being tested. And 10% was diagnosed positive, and 37% of those diagnosed positive started ART. As you can see, for the rest of the key population, so a step toward new Malaysia. As everybody knows, Malaysia is having new governments. Is the first in the history. So what we hope for moving forward is creating an enabling environment, elimination of stigma and discrimination, collaboration and partnership, community empowerment, human rights and social justice, acceptance, political will and commitment. As you can see in this picture, this is one of the sessions that we have at government clinic where we sensitize nurses and doctors and healthcare providers at government clinics so that they understand the nature of key population and hopefully there's no stigma and discrimination. So in this year, we did assessment for this program, and what surprisingly, and this is the success story that we feel is very important for this program. So one significant finding is through interviews and assessment, there's no stigma and discrimination found at government clinic with the program that we're working with. So with that, thank you so much.
Thank you, Dr. Hakim. Anybody who has questions, I think we have some time for some quick questions. You can just come to the microphone, introduce yourselves, and ask your questions.
Hi, thank you. It's Julie Franks from ICAP. And I'd just like to hear more about, there was some reference to sexual transmission, sexual networks being responsible for a majority of the transmission that you found in your HIV testing. I saw on the slide, but you didn't mention it in your talk. Could you tell us a little bit about what you're doing with sexual networks for either reaching people for testing, or is it index case testing?
Okay, first of all, sorry. Hello. Okay, first of all, Dr. Pungguli, I'm not a doctor. So, regarding your questions, using social networks that we have in the community, it builds trust because it's peer-to-peer programs. Our MSM reaching out to MSM, transgender reaching out to transgender, and female sex worker reaching out to female sex worker. So even though with all these barriers that they build trust among themselves, and it takes time for community members to go for testing. So either through community-based testing or government clinics. So what we do for community-based testing is our community members being trained to do tests, HIV screening themselves. And based on that, our community members doesn't really have to go clinics, or they can do at field for community-based testing, or they can choose either they want to go for clinics. But it's really based on trust and relationship between community members and our caseworkers or outreach workers.
Thank you.
Thank you.
Hi. Hello, I'm Eve from Haiti. So I have two quick questions. First of all, do you have any size estimation for your key pop, particularly MSM and female sex workers? Second, on an M&E basis, how you can make sure that these numbers that you're reporting are not double counting? I mean, you're not counting the same MSM or female sex workers again and again. So how do you cope with that on an M&E plan? Thank you.
So first of all, the first question about population size estimate. So we have the population size estimate. What I've shown in the slide just now is the previous population size estimate, but we have the current one. It's not official yet, so I cannot share. But basically, we have about 170,000 MSM in previous population estimate, and about 40,000 of sex workers that comprise of transgender and female sex workers. So in terms of M&E monitoring and evaluation, to make sure that it's not counted, we have a tool to make sure that this person is not the same person using the UIC code, which is a unique code for our client.
Thank you, Dr. Hakim. We will now move on to the next presentation.
Hello, maybe. Can I ask a question? Yeah, thanks for your presentation. It's Stephen Pan from Xi'anjiaotong Liverpool University in China. I'm kind of curious about, if you're wondering if you can comment about intersectionality regarding MSM status and ethnicity and religious affiliation. Notice you showed a slide with Malay, Chinese, Indian, and other, and how this intersectionality might have complicated or your efforts to reach out and increase testing. And a second related question is maybe if you were able to interface or engage with any religious leaders, maybe imams or whoever, to help increase testing among the community.
Thank you. Very good question. So, as I was explaining earlier about the comprise of different ethnicity, so the Malays is bound to Sharia law, which is more difficult to reach because they're subject to certain provisions and law if they found out with all this, anal sex, oral sex, and so on. But through our engagement with stakeholders, as I mentioned, the religious department, religious leaders, so we'll be able to make them understand the importance of this initiative from the public health perspective, so that we can continue doing our programs and reaching out to this population. Thank you.
Social networks pretty discreet or within the MSM community, I assume?
Well, it depends. It's really difficult for them to really openly say they are gay. So there are many hidden MSM, even though there are some groups that some MSM mobilize themselves and form up a group. But through Malaysia Aid Council and with partnership with government, we make them understand that this group is to respond to HIV and epidemic in Malaysia, so that it's make our response much easier rather than if they go hidden. Thank you.
The next talk will be on extended risk network testing in key populations in Ukraine. To have this, we have Dr. Yulia Sereda, who's an independent consultant providing consulting services for HIV Reform in Action, the USAID project Alliance for Public Health, and the Ukrainian Institute on Public Health Policy. Welcome, Dr. Yulia.
Okay. Hello, everyone. What I would like to do today is to discuss how we can improve HIV case finding with machine learning. And first, I would like to acknowledge my colleagues from Ukrainian Alliance for Public Health who provided data as well as their insights and expertise that greatly assisted my research. And a special gratitude I give to Dr. Friedman, who has invested his full efforts in guiding our team. I declare no conflict of interest. So, well, we have many concerns regarding the gap in achieving the first 90. And almost half of people living with HIV in Ukraine are unaware of their status, and that's higher than average in the Eastern Europe and Central Asia region. So this creates demand for innovative approaches in HIV case funding, in particular among hard-to-reach populations. So we have different strategies how to improve this HIV testing, but a little was made in bringing machine learning expertise to this field. So for the last 3 years, Alliance for Public Health implements extended risk network testing during community-based outreach to optimize HIV case funding among key populations in Ukraine. We were wondering to what extent we can improve this intervention with embedded machine learning algorithm. So the purpose of my talk today is to inform you about prediction models we tested for finding HIV positives in this intervention. So let's start by looking at brief country profile. Ukraine is an Eastern European country with a population about 40 million people. Adult prevalence is about 1%. Actually, we have concentrated epidemic, which is mostly concentrated among people who inject drugs, with about 23% prevalence in this group. Other groups with high prevalence are female sex workers and MSMs. So I would like to take a minute to exactly define what we mean by extended risk network testing and machine learning. Extended risk network testing is an intervention based on social network strategy. Basically, participants identify and recruit persons for HIV testing from their social, sexual, or drug using networks, and who can also be at risk of HIV. It's extended in a sense that we reach not only immediate risk partners, but those who might be sharing the same risk cluster. In Ukraine, extended risk network testing has two-step design. It means that both HIV negatives and positives could recruit their peers. However, recruitment is stopped if there were two HIV negative cases next to each other, like here or here. It must be remembered that this intervention has both advantages and limitations. It has proven effectiveness for increasing yield in HIV testing among hard-to-reach populations compared to usual outreach screening. Project REAP result, which was the first ever study included risk network testing in Ukraine, is particularly informative for this. Table shows a tremendous difference in yield for HIV testing achieved by using these two strategies on the same time period in Odessa region in Ukraine. At the same time, this intervention depends on incentives, and its effectiveness could be less in small residential areas or among shorter or discrete networks. Now I would like to move on to machine learning concept. So I'm talking about some complex mathematical algorithm that can learn from and make prediction on data. It's like real-time data analysis. And the premise of machine learning is to build an algorithm that can receive input data and use statistical analysis to predict its output while updating outputs as new data becomes available. In HIV research, machine learning was mostly utilized in treatment and drug development, such as predicting drug resistance based on genomic data or making so-called personalized drugs. Few studies presented benefits of machine learning for case finding and surveillance. For example, there is a study that find and target cases of risk behaviors on Twitter or predict AIDS incidents based on search queries in China. Some details about methods. As I mentioned before, extended risk network testing is ongoing intervention. So we worked with a data set extracted at the beginning of this year. In total, over 50,000 participants were recruited in 12 regions of the country during 2 years. Recruitment started from people who inject drugs who were over 14 years old and received HIV-positive rapid test result in NGO. And participants could recruit their injecting partners, sexual partners, or sexual injecting partners of somebody from the social network who can be also at risk of HIV in the opinion of recruiter. Recruiters received up to 8 coupons, and all participants completed short screening face-to-face interview on demographics and behavior and received assisted HIV rapid test. Compensation payment was not high, it's about $2 for the interview and $1 for recruitment. And we use Cyrex Cloud, which is a cloud-based data management system with mobile application developed by Alliance for data entry, client registration, coupons, and rewards management. A few words about data analysis. So we worked with a subset of participants who received coupons, and missing data were imputed. We predicted the presence of HIV positives in 2 steps from the index case and analyzed features linked to that outcome. In total, we tested 9 machine learning algorithms. You can see them on the slide, and all data analysis was conducted in R. So, some results on recruitment and demographics. Less than half of screened participants received coupons. Among those who received coupons, 80% recruited at least 1 peer. In total, HIV yield was 15%. A quarter of participants were females with a mean age of 35 years, and nearly 80% of recruited participants were people who inject drugs. I just want to remind that they're the largest key population in Ukraine. Well, this is actually our key slide. You can see the results of algorithm testing, and that's pretty impressive. We reach 85% accuracy in predicting who will recruit HIV positives. That's amazing. So we are 85% accurate in prediction who will recruit HIV positives and who is not. Let me a short digression here. At the beginning of the intervention, all eligible participants received 3 coupons to recruit their peers. The approach was not really successful, so we decided to give more coupons for participants who had characteristics linked to HIV status based on previous research in the country. And data analysis showed no evidence for the effectiveness of this strategy, so more coupons per person didn't result in high yield of HIV. And that brings us to the issue, what characteristics are really important for predicting the recruitment of HIV positives and therefore improving our yield. And here is an example of variable importance in random forest algorithm, which was one of the best. And here are the values of mean minimal depths. It's a measure that shows variables important in split-in classification. The low value is the most important variable. So it turned out that network size was the key variable in predicting who will bring HIV positives. Besides this, age, wave of recruitment region, and the result of on-site HIV tests were important. It wasn't expected, but most of the questionnaire variables we had, such as demographics, except the age or behavior, were not helpful in predicting the outcome at all. And essentially, the high accuracy we reached were just a combination of 4 variables: on-site HIV test result, region, network size, and age. So to conclude, I just want to draw your attention to key points. First, high level of prediction model accuracy suggests that application of machine learning algorithm during recruitment could improve HIV positive yield among recruited participants. Second, we should understand to what extent collected data is helpful in predicting the recruitment of HIV positives. Because, you know, we can't ask participants everything we want to know. It would be 100 pages questionnaire, just a nightmare. And we want to understand what variables we really need to make a good prediction. We totally understand that these important variables could be different in other countries or other epidemic contexts. And so we can develop some universal formulas, what characteristics of behaviors lead us to a better yield. However, if we implement these embedded algorithms during recruiting, this could be a universal key to these characteristics. So a few words about next steps. We recognize that there's still a lot of work ahead. We are going to continue the search for other potentially important features for predicting the recruitment of HIV positives, such as it could be stigma or information in co-infections. Our questionnaire was fairly short. Besides improvement of the questionnaire, we are looking for different criteria for seeds. And algorithm testing has not been finished yet. We are currently working on another algorithm, and we test Ansible models, so that's basically when multiple algorithms work together. And finally, the research will be transferred to the real life by implementing the best algorithm predicting HIV positives recruitment in Cyrix Cloud mobile app, and we will use it for smarter coupons dissemination. Thank you for listening.
Yes, go on.
Thank you. Oh. Hi, thank you for this presentation. It was great. Did you look at any other, I'm Britt Scathan from UCSD. Did you look at any other network metrics such as bridging or density and how they predicted?
Mm-hmm. Great question. Unfortunately, no. We were limited in the collected data and we couldn't look at these characteristics, but we are going to do that.
Thank you.
Thanks a lot for the presentation. 2 questions. How did you manage to get the statistics on the number of MSM men in Ukraine?
I'm sorry, the number of what?
MSM, men who have sex with men.
That's a population size estimate.
Okay.
We have population size estimates for all key populations in the country.
Okay. And another question about sample. How did you manage to survey 51,000 people? How was it possible?
Actually, it's a pretty big intervention. It's implemented in 12 regions of the country, a bunch of NGOs, and that's a sample for 2 years of recruitment. And it's an ongoing process, so now we have even more.
Wow, perfect. Thanks a lot.
Microphone number 4, please.
I just have a question, probably more specifically to the whole panel.
Excuse me, can you introduce yourself?
Yes, sorry, my name is Navon. I'm a trans masculine person with Global Action for Trans Equality. I wanted to ask a general question to the panel about whether you've considered in any of your research, specifically including trans men in key population data, because there are a huge number of trans men who have sex with men who are either lumped into cis women data due to lack of understanding of who trans men are and also an assumption of what body parts we use to have sex, or we're just excluded completely from MSM data, yet trans women who are not men are included in that data, which is equally problematic. And we're finding throughout this whole conference that trans men are not mentioned in any MSM data, in any presentation at all. And as this is a discussion about key population, I was really hoping that trans men would be included, yet we're not, once again. So I'd like to put a question to the whole panel on how you think best this can be addressed. Thank you.
May I respond to that question?
Sure.
Sure. While we note the importance, can you hear me? Hello. Okay. So we know that the importance of including trans men in MSM data. So it's very important because it's two different things within sexual orientation and gender identity. So trans man is gender identity and the sexual orientation is homosexual or heterosexual. So in Malaysia, we did a small study to to find out the population size estimate of MSM who use dating apps online. So we include that in our questions, that either you are trans man or you are male. So I think it's very important in any data also to include trans man, because it's to differentiate between sexual orientation and also the gender identity. So looking at the HIV response perspective. I hope I answer your question.
You kind of just explained what the difference was between trans men and, gender identity and sexual orientation. As a trans person, I know that. I don't want you to tell me who I am. I want you to tell me how you're going to start including us in data research into HIV resources, because there just are none at all. No research, nothing on PrEP, nothing on PEP, nothing on viral load suppression, just nothing. And that wasn't an answer to my question, sorry. So I'm wondering if someone else maybe has an answer?
Thank you. That was a very important question. I think that was raised in a previous session as well. What is important is I just want to draw an analogy to what we did to the Women's Health Committee from the ACTG, because we found that even at CROI, there weren't many data that was actually analyzed for women-men specific differences, though it could have been done. So generally, it was just extrapolated. I think what needs to be done in this particular context is that studies are specifically designed to address these populations as separate groups, rather than make it a monologous group of, generally say it's MSM and key population. Now that we have more data and evidence and more work going on in these key populations, I think it is very, very imperative and need of the hour that we need to make it a part of the study design and the analysis that these groups are addressed separately, so that we do not say that what is applicable to the MSM is applicable to whatever is covered, and it doesn't come under blanket. I think the distinction has to be made at the time when these studies are designed itself. Does it answer your question?
Yes, thank you.
Thank you.
Thank you.
That's the last question for this. We have to move on to the next speaker. You can go on, yes.
Okay, thank you. My name is Atch. I'm Jeremiah Howard. I'm from the United States, and I'm an openly HIV positive trans man. And I find it very problematic to come to a conference, and I know there are trans men who are here who are HIV positive as well, and we are not even included in the data at all. So I find that very problematic for us to come to a conference and we are excited to get the information, but the information is not there. So I pray that in the future, in 2020, that we will have more data on trans men, and we'll have data on trans women, because we are a part of the community too. Our health is important just as well as anybody else's. Thank you.
Thank you. I invite Dr. Anne Gosselin for the next talk. She'll be talking on the timing of determinants of post-migration HIV acquisition in France. And Dr. Anne Gosselin holds a PhD in public health. She's a postdoctoral researcher. Her main focus on work is on interventional research, aiming at improving sub-Saharan migrant sexual health in Paris area.
Hi, good morning, everyone. So I'm going to talk about sub-Saharan African migrants in France and about the timing of their HIV post-migration acquisition. So just to give you a little bit of background about France, so immigrants from sub-Saharan Africa represent 13% of all immigrants in France, and that's a population about 800,000 of people, and they are a key population for HIV epidemics. So they represented 31% of new HIV diagnoses in 2013, and it's mainly heterosexual transmission. And what is becoming more and more, there's more and more evidence in the recent years, is that actually the proportion of persons who've been infected after migration is quite important. Maybe you've already heard about this result, but before we used to think that maybe people got infected in their origin countries and travel to Europe, but actually that's not true. There's an important part of them who acquire HIV in Europe, in this case in France. The figure is between 35% and 49% of immigrants living with HIV actually acquired it after arrival in France. So that's very important in terms of prevention, that the stress should be put on prevention among this population as well. But today, we had no idea of the timing of this post-migration acquisition. What I mean is it something that occurs in the first years of arrival when people are getting settled, or is it something that affects all immigrants, whatever the date of arrival is? So the purpose of this study I'm presenting here is to estimate the timing of this HIV post-migration acquisition in France. So in terms of methods, I'm using data from the INRS Parcours survey. Parcours is a French word that means trajectory. It was led in 2012-2013, and it's a retrospective life event survey. So basically, when I'm talking about immigrants here, it means everyone who's born in a country of sub-Saharan Africa, whatever the legal status or current nationality is. And so this is people between 18 and 59 years old who were included. And basically, they had a life event questionnaire. That means very detailed data year per year on the country where they were, the housing situation, health situation, of course, work situation. So we have very detailed data on very different domains. And also a medical form filled by the doctor with biological data. I'm going to talk a bit more about that later. So in this presentation, I'm going to talk about two groups that were randomly sampled in this study. So the first group are immigrants living with HIV. They were recruited in hospital services, caring for people living with HIV. And then a group of people not diagnosed with HIV. And these people were recruited in primary care centers. And that includes services particularly addressed to undocumented migrants. So we have a very diverse population in terms of recruitment. So basically what we do, first thing is we look at how settlement goes in this population. And basically, when I'm talking about settlement here, it's a very basic definition, having a first personal house, first stable resident permit, that means at least a year, and first paid job. And when someone has those three elements, we estimate that person is settled. And we saw that in this particular population, it takes 6 years to have these elements. So it's a long period of when people do not have all these three elements of settlement. But the period in median is 6 years. So now we take, for this particular study, 708 persons in France who were at least for 6 years in France. So we have the same period of observation we observe persons for at least 6 years. And then we have 277 people who acquired HIV after migration, and that we know from the previous work, and also 431 persons who are not infected. So basically what we do is that we estimate among the persons who acquired HIV after migration, were they infected before settlement, the 6 years, or after settlement. And we do that using a combination of life event data and biological data, and I'm going to explain a bit more afterwards. And when we have that, we can give a percentage of people who are actually infected in the first years in France or afterwards. And then I'll describe a bit the three groups. So people who are infected early, people who are infected lately, and then who are not infected. So to give you a sense of who those three groups are. So I'm taking you through this graph. So if we take the 277 people infected post-migration, we have a series of life event criteria that allows us to assign whether they were infected before or after settlement. So basically, if a person had an HIV diagnosis 11 years or more after 6 years in France, then we can estimate that the infection occurred after 6 years in France. Second criteria is if the person had at least one negative HIV test after 6 years in France. Again, we estimate that the infection occurs afterwards. After 6 years in France. And then last life event criteria is if the person has a sexual debut after 6 years in France. Again, we estimate that the infection occurs after 6 years in France, after settlement. But then there's a remaining group, 184 people, for whom we do not have this information. And for this group, we use a method that's now widely used elsewhere, using biological criteria. So basically, we take CD4 cell count at diagnosis, and we can model the CD4 cell count decline, and we can estimate whether, taking the slope, we can see whether the infection occurs after settlement or before settlement. And when we've done all that, the result is that we have 42% of sub-Saharan African immigrants living with HIV that were infected after settlement, after 6 years in France. So if I show you this in a more graphical, visual way, basically, among sub-Saharan African immigrants infected after migration, we have 58% were infected before settlement. That means that the 6 years, the first years in country, in France, are really a key period where there's a higher risk for people for infection. But then there's still 42% of these people who are infected after settlement. They've been in France for many years, they're settled, but still there's a risk for them to be infected. So now, if I just look at the group, I'll show you men and per sex. This slide is the infections before settlement. And for this group, we find something that we expected, is that the people who get infected before settlement are more exposed to social hardship experiences. And that's something we already investigated before. For example, you can see that in men, for example, 75% of men infected before settlement experience a year without a legal permit. And for women, it's 57%. And it's more than the reference group, the persons who were not infected. And for women as well, you have more women who had a year without stable housing. And for women, that means we also have, more casual transactional relationship during this period and more concurrent relationships. And we were expected that because that was shown in a previous work, but we're kind of curious about the second group. We know that social hardship exposes people to infection, but what happens for people who've been infected, they were in France maybe for 10 years, and is there a particular profile of people who are being infected? And the answer is no. The answer is there's no particular profile for this persons who are infected lately. They're very similar to the reference group, to the people who were not infected by HIV. I'll just put a few demographics here. The only difference is that in women, we have more women who came for family reasons, but that's a very typical motive for coming to France. So basically, the reference group and the people who are infected after settlement are quite the same. And what does that mean? That means that probably the main reason behind this is that the sexual network is just people are more exposed to HIV in their sexual network, and there is no specific profile that puts them at risk. So really, in terms of perspective, there's a double message here. The first message is we have 58% of sub-Saharan African immigrants who acquired HIV in France who got infected in the settlement period. That means that we should accelerate the settlement period for these people because we know that social hardship puts them at risk, and probably prevention programs should actually target people who are newly arrived in Europe. But there's still 42% of them who acquired it after the settlement period, and that probably means, but that's still discussion, that we should design more interventions, prevention tools that are specifically tailored to this population, so all of them have access to combination prevention. And the Parcours Study Group is a very big research group. You can find all the results at this website, and I thank you very much for your attention.
Hello, I'm Henry de Vries from the Public Health Service in Amsterdam. Thank you for this presentation. Could you elaborate a little bit more on the way you sampled, especially you said it was a random sample. How did you do that?
So for each group, for example, the HIV group, all eligible patients who were HIV positive diagnosed for at least 3 months for ethical reasons, who were the age range and born in sub-Saharan Africa, were proposed to participate by the doctor. And if the person accepted, then the doctor had the informed consent. And that was, we randomly, for the random thing, we randomly chose services. Like we had a database with all the services that takes, there's HIV care, and we randomly sampled these services.
But is that a random sample?
Yes, it's a two-stratified random sampling. So the service is stratified, and then the day of survey.
Thank you.
You're welcome.
Are you waiting to ask a question?
Yes. Jun Yu Wu from China CDC again. Very wonderful study. When I saw the figure, I may misunderstood, and 42% are infected after settled for 6 years. And later on, I look at the overall data, is actually the proportion, right? You have 58 proportion before 6 years, and 42% proportion after, right? So what is the incidence rates among migrants? Compare incidence among migrants with the local French, is that much higher than the local residents?
I didn't have the incidence rates with me here, but what I can say is that in terms of new HIV diagnosis per year, yes, the first at-risk group is MSM in France. That represents more diagnosis. And then you have sub-Saharan African immigrants, it's 31%, and then IDUs, but much less persons. Does that answer your question? Yes.
Hi, I'm not on mic. Hi, I'm Travis Sanchez from Emory University in the U.S. And I think from your concluding statement, it seemed like you were determining that the time in which someone was acquiring HIV infection related to their settlement was indicative of their network, their sexual network, or their drug-using networks, and that by shortening the settlement period, you potentially could change their network risks. And can you talk a little bit about that?
No, maybe I was not very clear. Actually, what I mean is that we know that during settlement, the social hardship experiences puts people at risk. And what I mean by that, you have very particular case of false sex, transactional relationships, especially for women, but also the fact that when you don't know where you're going to eat or sleep, the prevention is not your first priority in your head. But what I mean is that for the people who are infected long after settlement in France, they've been there for many years, they're not especially in a social hardship situation, then the explanation that remains is that if they evolve in sexual networks that are more exposed to HIV, then they just have more risk to meet the HIV virus, so to say. So there's no particular profile or particular behavior, it's just that they're more at risk. You're welcome.
You have a question?
Well, should I go ahead?
Maybe you can. We're really short of time.
Okay.
Sorry. We move on to the last but not the least speaker, as is customary to say when you're introducing the last speaker for the session. We have Dr. Newcomb, who's an assistant professor in the Department of Medical Social Sciences at the Northwestern University. And his main focus of research is in identifying drivers of health disparities among the key population. And this also includes issues relating to substance use and mental health problems. Over to Dr. Newcomb.
Do we have my presentation? I don't think I've memorized the whole thing, so I'm not sure I could just say it off the top of my head. Oh, there. Forward? Okay. No. Okay, I can at least say the title of my talk and acknowledge my my co-presenters. So today I'll be talking about patterns of substance use, in particular patterns of polysubstance use in a large cohort of young men who have sex with men in Chicago, as well as examining in classes of polysubstance users associations with HIV risk behaviors and STI infection. And I'd like to acknowledge my collaborators, Gregory Swan, as well as Dr. Brian Mustansky, who's the PI of the study from which these data came. Still struggling. Oh, okay. Aha. Bingo. Okay. So first of all, as many of us know in this room, substance use is one of the most robust predictors of sexual risk behaviors and HIV infection in both young and adult men who have sex with men, not just in the United States, but globally. In the United States, black young men who have sex with men are actually less likely to use substances than other racial groups, yet they have the highest HIV incidence rate of any group in the United States. Most research on substance use thus far has examined individual substances as individual predictors of HIV risk behaviors and HIV infection. However, characterizing patterns of use, so by this I mean patterns of polysubstance use, what substances are used concurrently, may help to clarify associations with HIV risk. So the data that I'm going to present today come from a large longitudinal cohort study in the Chicago area called RADAR. This is an ongoing longitudinal cohort of young men who have sex with men that aims to understand multi-level influences on HIV risk and substance use that's funded by the U.S. National Institute on Drug Abuse. In terms of the characteristics of this cohort, at enrollment in the cohort, participants were between the ages of 16 and 29 years of age, were either young men who have sex with men or transgender women. And this cohort was built by hybridizing or bringing together three pre-existing cohorts of individuals. And each of these cohorts was enrolled in 2007, 2011, and 2015, respectively. At the time of enrollment into their original cohort, all participants were between the ages of 16 and 20 at baseline, were assigned male at birth, and currently identified as gay, bisexual, queer, or endorsed attractions to other cisgender men, or had had sex with a cisgender man. Currently, we have ongoing data collection from 7 visits, which are administered at 6-month intervals. But the data that I'm going to be presenting on today are in an analytic sample of the 16 to 20-year-olds at the baseline, which is began in 2015, which is a total N of 601 young men who have sex with men. Here are the characteristics of the entire cohort study. So again, today I'll just be presenting on the individuals who are between the ages of 16 and 20 in 2015. However, you can see that we have a fairly even distribution of participants across the age range of 16 to 29. We also have a fairly even distribution of racial or ethnic groups, and this distribution matches approximately the census data from the city of Chicago. In terms of sexual orientation, this is predominantly a gay-identified sample with substantial subportions of bisexual-identified individuals and other sexual orientations. And this is predominantly a sample that identifies as male, so predominantly a cisgender male sample. In terms of the analytic approach for these analyses, we conducted latent class gross analysis in M+ to identify substance use classes across the first 5 waves of data collection. And the substance use indicators that were included in these models were binge drinking, an indication of disordered marijuana use, stimulant use, ecstasy use, and prescription drug use. These are the most frequently used substances in our sample in Chicago. We examined model fit through various indicators of model fit that I won't go into today. And what we found after conducting these analyses was that the intercept-only models provided the best fit. So what that means is we didn't see substantial change over time or substantial growth in substance use patterns across the first 5 waves of data collection. So instead of providing this longitudinal data today, what I'll be doing is presenting data on the a 4-class solution that's just based on baseline data. After we created these 4 classes of substance users, we conducted analysis of variance in SPSS to test for differences between the 4 latent classes in demographic factors, sexual risk-taking behaviors, and STI rates. In terms of results, this graph illustrates the 4 different latent classes of substance users in our sample. Latent class 1, which is about a quarter of the sample, are what we're calling the binge drinkers. So they have a high likelihood of binge drinking and a low likelihood of use of other substances. Latent class 2 are the binge drinkers and prescription drug users, which again is about a quarter of the sample. These individuals have a high likelihood of binge drinking and a moderate likelihood of prescription drug use. Class 3, which is just over a third of the sample, is the low substance users, so a low likelihood of use of any substances. And the final class, which is about 12% of the sample, are high substance users, a high likelihood of binge drinking, and a moderate likelihood of disordered marijuana use, stimulant use, ecstasy use, and prescription drug use. Next, we examine demographic differences in the likelihood of belonging to one of these 4 different classes. First, we found significant differences in race ethnicity by class. So we found an overrepresentation of black YMSM in the low substance users class, which is consistent with prior research. We also found an underrepresentation of black YMSM in the binge drinkers in the high substance users category. We also found an overrepresentation of white YMSM in the binge drinkers and prescription drug users class. And an underrepresentation of white YMSM in the low substance users class. In terms of sexual orientation differences, we found that bisexual YMSM were overrepresented in the low substance users class and underrepresented in the high substance users class, which is actually inconsistent with some prior research that indicates that bisexual individuals have a higher likelihood of substance use. Finally, in terms of age, this is the mean age in years, we found that our younger YMSM were more likely to belong to the low substance users class. In terms of sex behavior differences in class membership, we examined sex behavior differences concurrently, so reported at the same wave at which we assigned their latent class of substance use. And we also used the substance use classes to predict sexual behavior 6 months later at the 6-month follow-up time point. What we found was that consistently across all indicators of sexual risk, so total condomless anal sex partners as well as total condomless anal sex acts, both concurrently and predicting 6 months later, we found that the high substance users class had the highest rates of sexual risk behaviors. And this was followed by the binge drinkers and prescription drug users class had the second highest rates of sexual risk behaviors. And we note that the low substance users class, as expected, had the lowest rates of sexual risk behaviors. In terms of STI prevalence and PrEP use, or biomedical outcomes, none of these differences were significant by class. However, this is likely due to the fact that we had a relatively low number of PrEP users at baseline, as well as relatively low numbers of STI infection. So what we see here is that we have what I'm going to generously consider a trend, which is probably untrue. But we see that STI infections did differ somewhat by latent class. So the highest rates of STIs, these are rectal chlamydia and gonorrhea infections, were observed in the high substance users class. However, we found that the second highest rates were observed in the low substance users class, which, as you remember from above, these individuals actually had the lowest rates of sexual risk behaviors. This is clearly not a significant finding, but we did also observe that the highest rates of PrEP use were in the high substance users class and the binge drinking and prescription drug use class. So what does this all mean? First, in these analyses, we were able to observe 4 distinct groups of substance users. The high substance users and the binge drinkers and prescription drug users class reported the highest rates of sexual risk behaviors, as well as the high substance use class reported the highest rates of STIs. So clearly these are groups that are good candidates for pre-exposure prophylaxis, as well as if these individuals are HIV infected, engagement in care so as to reduce or to suppress viral load. However, these individuals in both of these classes were mostly white YMSM, but we know from our epidemiological data in the United States that most new HIV infections occur amongst black MSM. Interestingly, the binge drinkers and prescription drug users classes not previously been identified in the literature as a specific high-risk group. So this has the potential to be an emerging high-risk group as we're observing that misuse of prescription drugs is increasing amongst YMSM. However, black YMSM were largely in the low substance users class. They reported the lowest rates of sexual risk behaviors, but had a relatively high STI incidence. So it's clear that there are various other factors at play that are causing these higher rates of STI infections as well as HIV infection. And these are things that we need to examine more thoroughly. Latino YMSM, you'll notice I didn't say much about Latino YMSM in this presentation, which is interesting because we're beginning to observe in the United States a sharp increase in HIV incidence in this population. They actually have the highest increase in new HIV infections, and we didn't observe any patterns of differences in which Latino YMSM were more prevalent in certain groups versus others. So it's clear that we need to do more work to understand the unique risk factors of Latino YMSM. And finally, putting this all together, we need to address barriers to PrEP uptake and engagement in care for YMSM of color, because clearly simply by working on substance use interventions, that's not going to eliminate the racial disparities that we see in HIV infection among YMSM. And finally, I want to just echo some of the comments that individuals made earlier about the inclusion of transgender and gender diverse individuals in research. This is a priority of the research that we conduct at Northwestern, and we hope that in the coming years we'll be able to receive funding to build a cohort of transgender and gender diverse individuals so that we can investigate the unique risk factors of those diverse populations rather than simply lumping them into the existing cohorts that we have. Thank you.
We have just time for 2 quick questions. Are there any? Yes, the gentleman at microphone number 6.
Hi, my name is Marcus Sandling. I'm from Mazzoni Center in Philadelphia. And I had a question about maybe underreporting of African Americans for the actual sexual risks and why the data is showing that these patients don't seem to be reporting much risk, but they're actually having much more STIs.
Sure. Interestingly, we conducted a study several years ago now. It was probably 5 or 6 years ago now. We had a paper come out where we examined basically converging evidence to try to see if indeed certain groups of YMSM were underreporting their sexual risk behaviors. So we assess all of our sexual risk behaviors in what we call a partner level model. So we ask specific characteristics about partners. So what we would expect would be that if indeed a certain group, say Black YMSM, were underreporting their sexual risk behaviors, then when other racial groups were reporting on risk behaviors with Black YMSM, then we would see a disparity between those two groups in the rates of risk, which we didn't actually observe. So from our work and the work of many others, it appears that it is indeed true. This is a consistent finding that Black YMSM in the United States report substantially lower rates of sexual risk behaviors.
Great. Thank you.
Yeah. All right. Thank you.
So thanks to all the speakers for the wonderful presentations, and thanks to the audience for your participation and patiently being here all this while. And we need to appreciate all these efforts to really reach these hard-to-reach populations. And we should also like to echo I think the panel would like to echo the need of the voice of the community as well, that we need to appreciate that when we design studies and interventions in these populations, we actually classify them and group them into what it is actually, and make sure that the results can be extrapolated to the individual groups. And this, I think only then we have reliable results, and we can really fine-tune our interventions so that we can reach all these groups, especially in this era when we are rolling out treatment for all and PrEP across the globe. Thank you so much. I also like to acknowledge all the help of the support staff, the audio, video, and the stage team, and the volunteers here for the active support and help. Thank you.